Right, I've got 2 more minutes on my thing, so I'll just wait while people log in.
We all look very solemn. We're either solemn. Are we solemn or hungover? Or as a non-drinker, I can say that. So.
Anticipatory, I think, Heidi.
Yeah.
I think that's right. I think that's right, Nikki. You've nailed it.
It's a bit like the start of a race, isn't it? You know, when nobody looks at each other and you're just waiting for the gun to go. I don't know why I thought of that. It must be at least 40 odd years since I've done anything.
I was going to ask Alison, when were you racing?
See, in my head, I'm still so young.
Aren't we all?
Oh. Right, where are we? Right, well, that looks, my list is quite long now, so I think probably we've got virtually everybody that we're expecting. So I will kick off. So good morning, everybody, and welcome to the meeting today. Could I just ask a bit of housekeeping? Obviously, if you're not speaking or anything, if you could stay on mute, that's really helpful so we don't get any echoing. That would be great. So again, welcome and apologies. I've got Luke, James and Andrew Blakeman. Have we got any others, Kwame?
No, just the 3.
Who was the other one?
Just Luke, Andrew, yes, no, 2.
2. Oh, thank you very much. That's great. Thanks. Any declarations of interest from anybody, please? No? Thank you. Minutes of the last meeting. Now, I know there are 9 pages, so I think probably what I'll do is just to ask if anybody would put their hand up if they have any corrections, amendments that need noting. No, great, thank you very much. So those are approved. Matters arising. I think everything's covered on the agenda unless anybody has noticed something that we're missing, if they could let me know. No, okay, that's great. Thank you very much. Right, we go on to my verbal report. Just a few things since the last update. Integrated care system meetings have continued, which I've been attending. They're going to have a development day in October, which will be interesting, give us a chance to get together for a slightly longer period of time working as a system on probably the strategy and other things. There's a new framework that has come from the Department of Health around the governance for integrated care systems, which we've been discussing recently. And I think basically the feedback that's going back from all of us is to keep it as least bureaucratic as possible. We're very concerned that we'll lose the ability that we've had over the last year to act much more quickly and collaboratively. So I'll keep you aware of what's happening there. Joe and I will be meeting in August with our counterparts at the Bedford Hospital Trust to have some discussions, and that's around obviously our collaboration and the integrated care system. Next week I'm off to the Parish Council at Woughton. It's one of my early external meetings with groups, community groups, just to see what they're doing. They're doing some very interesting work there, so I'm looking forward to finding out more about that. Been keeping in touch with the networks, the staff networks. There were some great presentations at the event in the tent, and I recently attended the launch of the Veterans Network for those who are either serving or retired service personnel in the organisation and their families. So there's some interesting plans there, which please do. I think they will be having something on the web for contact, so do keep an eye on. I think they've got some great plans. The regional chairs meeting, there is a big push around the anti-racism agenda. Basically we're given a sort of a steer and an expectation around our region, particularly around recruitment, promotion, reducing inequalities. So there's quite a piece of work going on there, which is obviously the expectation is all organisations will respond to that. At the NHS providers meeting for chairs and chief executives recently, there was a lot of discussion, particularly around recognising significant change in the NHS now with a new Secretary of State, and we're also going to have a new chief executive for NHS England. So lots of discussions around there around what that might mean. Obviously recognising the challenge to meet the backlog in terms of services for the NHS across the country, not just this area. Obviously discussion around plans for the winter, not surprisingly, particularly around COVID and flu, and how that's going to be dealt with, but also obviously the long-term COVID impact that's likely, and obviously anything else that as we go into July, further into July and August, the impact of the reduced restrictions and how that might impact on the NHS in the winter. So as you can imagine, a lot of focus around those potential difficulties coming up. There's also a lot of discussion around digital transformation, which I always find very interesting, knowing how much is going on at Milton Keynes Hospital. And so I keep sort of trying to flag it up. You know, there's a lot going on here already, which you know, they could probably learn from, actually. Carried on more visits. I'm sure for the next year there's still plenty of places for me to visit and people to meet, and I also have visited hotel services, which was great to see all that sort of background work going on, which is so crucial. And I was able to find out as well just how much they'd risen to the challenge over the last year in terms of all the infection prevention and control. An extraordinary amount of work for such a small team. It was really impressive. And I think they were talking about deep cleans, but they were saying that, you know, in a normal course of events, they'd sort of do 300 and they were doing over 1,000 during the pandemic. So, I mean, it's just a real feat. So all credit to them. And that's really just my update just since the last meeting. Any questions at all? No? Thank you very much. Joe, I'll hand over to you.
Thank you very much, Chair. So a few things on my list. This week we published our yearbooks to celebrate the 73rd anniversary of the NHS. That has gone down very well, so well in fact that we are going to do a second volume of it as departments and teams come forward and want to record their story. So we will publish that as it becomes available. Secondly, I'll bring Ian in a moment. We have obviously been focusing hard on activity. The board should be aware that unfortunately we lost one of our laminar flow theatres, which is specific for orthopedic joints because of a technical problem. So we've had to postpone a few patients, unfortunately, there. We are trying to get back that activity as quickly as we possibly can. But just so you're aware, that sort of hampered us somewhat over the last few weeks. Ian, do you want to give an update on where we're at with COVID?
Certainly. So there's been a period of relative stability for COVID over the last 3 months or so, but over the last 3 weeks, I'd say we've seen a steady uptick in the amount of number of patients with COVID coming into contact with our hospital. I think in terms of the type of patients we're seeing, we are still seeing some patients who come in with symptoms of COVID and require treatment for it, so steroids, other evidence-based treatments. And we've had 2 patients and still have 2 patients on the intensive care unit as a direct result of COVID. However, the other factor I think it's important to point out is the community prevalence of COVID at the moment has been increasing significantly, almost exponentially. And that means we are seeing other patients who are coming in for other reasons who coincidentally happen to have asymptomatic COVID when they're swabbed. Now, in some ways, because of vaccination in our community, COVID is causing people much less harm, and we're seeing less of the severe spectrum of medical disease. But we will see pop-ups of COVID on our wards and elsewhere because of the asymptomatic carriage and the levels it's at in the community at the moment. So that's where we are. We're looking after the vast majority of our patients with COVID on Ward 22, and as I say, on ITU as well. So Ward 22 is particularly well catered for with side rooms, and it's a good environment for infectious disease service. So that's where we are at present.
Thanks, Ian. If I carry on and take any questions at the end, a couple of sort of physical buildings bits. We have moved the early pregnancy assessment unit to give it its own separate entrance. And for those of you that don't know, this is for women who are potentially suffering problems in early pregnancy. And so by providing that unit with a separate entrance, keeping it away from other mothers and babies, that is a real quality improvement. Obviously, it's not where we want to get to in terms of our new Women's and Children's Hospital, but as an interim measure, it's a very positive step. And we have also reopened Ward 14, which has been fully refurbished now. And if anybody went up there before it was refurbished, please do go and have a look at it now, because it really is a very nice, light, pleasant ward, and has lots of natural light coming into it, which is good. We're going to use that ward to enable us to decant one of Ward 1 into, which is our assessment unit, so that we can refurbish Ward 1. So we're doing that classic sort of children's game of having one empty slot and moving wards around whilst we refurbish them, because we know that Ward 1 is not a great environment. We're not going to do a huge amount of work to that. We're going to redo all of the flooring and improve some areas of it, but clearly, as our assessment unit, it is a critical ward. Once we open the pathway unit in the middle of next year, we will be in a position to do further refurbishment for all of our main wards. So this is a sort of stopgap. Moving on, we've had a lot of external communications, positive external communications over the last couple of weeks in terms of some of the service changes that we've made. We've opened the transitional care unit, neonatal transitional care unit, which is designed to keep mothers and babies together, which is a real quality improvement. We have launched the Hospital Navigator scheme, which is to support victims of domestic abuse when they come into our organisation. That's been very positively received. And alongside that, we've also launched for the team here at MKUH a policy to support paid leave for staff suffering from domestic abuse as part of our overall health and wellbeing agenda, which is very good news. Alison, you mentioned NHS providers and the work that they're doing on digital. We have now presented to a number of hospital boards around the country on the back of NHS providers asking us to talk about the digital journey that we've been on here at MKUH, and those have been very well received. We did one yesterday for Airedale. The joys of technology means that I didn't have to go up to Airedale, but I think we are getting the word out and supporting other boards on their digital journey, which I think is positive for the NHS as a whole. And then finally, on my report, we have done a piece for the BBC, which will either come out today or tomorrow, about the work that we have been focusing on around the Accelerator programme and how we've been innovating to see more patients more quickly and safely as part of being selected to be one of the national accelerator systems. So I'll pause there. I'll ask my colleagues if there's anything that individuals would like to raise. If not, I'll take any questions, Alison.
Great. Thanks, Joe. I don't think there are. No, I'm looking down. I haven't got any hands up at all. So, Joe, I'm just wondering about the lateral flow testing that's on the agenda and the objectives.
Yes, so if we move on to those, I'll ask Kate to update on the changes to the lateral flow testing, if I may, Chair, and then I'll come back to the objectives.
Morning, thank you. It's just to make the board aware that the system that we have been following for the ordering and reporting of lateral flow testing for staff has changed. So the reporting mechanism will remain the same. We have an internal system to report for staff to report twice weekly lateral flow testing results onto, but where we were supplying the tests internally through an internal ordering system, staff are now asked to order their own. That's a national change, not within our gift to influence. So staff now need to order their own test kits from the government central ordering system. We're asking staff to continue to test themselves twice a week and report their results on our own reporting system through the Trust intranet. So it's really important that staff continue to do that. We know that COVID infection rates are continuing to rise in the community and prevalence is relatively high and increasing. And so we're encouraging staff to continue with that testing programme despite the vaccination programme. Most of our staff, a huge majority of our staff have received both their vaccinations, but we want people to continue with asymptomatic testing and reporting. So we'll keep communicating with staff on that. We've sent some communications out and we've got a new communication system in the organisation where we can track who has picked up and read communications too. So we've got a better idea and understanding of how far our reach has gone with our comms, which is also positive for this kind of work. So happy to take any questions about that.
Thank you, Kate. Yeah, Helen's got her hand up.
Thank you, Kate, for the update. I just wondered how it's monitored. So you're encouraging people to do it twice weekly. I just wondered how it's monitored.
Yeah, so we can see who's, so we can track staff reporting and we can look at areas where there's low or high compliance in reporting. And Nikki and Ian have written to staff on a number of different occasions to encourage compliance and also so we can see by individual how many times they've reported and what their compliance rates are like, so we can manage that. And that's some of the reason why we've kept our own internal reporting system rather than shifting it all onto the government's national system, because we would lose that visibility otherwise. So we were able to track more closely, keeping that reporting internal.
Thanks, Kate. Ian, what's coming?
Yes, so there's obviously an interesting balance between confidentiality and occupational health versus infection prevention and control. So the internal reporting mechanism does mean there's really quite impressive granularity. All managers and appropriate members of staff can see that granularity, but they can't go all the way down to individual member of staff levels. They can look at a ward, for example. Myself and Nikki and other people we've authorised on the basis of a need to know basis can access the individual staff level data.
Thanks, Ian.
Thanks. Thank you. Okay, Kate, you finished, yeah? Thank you very much. Joe, back to you.
Thank you, Chair. Right, let's see if I can use the technology. Always good fun. I'll see if I can share my screen. Hold on 1 second. See. Can you see that? Does that come up as a shared screen? Yes, I can see you. Does that show? Yes, good.
Yeah.
Okay, so I will just try and put it on. Now I think you can see 2 slides there, but nevertheless I'll carry on. Current trust objectives, as you can see there, the board should be completely familiar with these. They are what we have been working towards for the last several years. And I think it's fair to say that whilst we have made good progress in a number of those different metrics, including also being seen by the national team and regional team as a safe pair of hands, I think what has been obvious is as we've gone through the pandemic, we are in a different place now, and there are some key trust-wide risks emerging around the length of time patients are waiting, the fact that hospitals are dangerous places, and that we do still have instances of avoidable harm for our patients, and overall our patient experience hasn't progressed as well as we would like it to, and as well as some of the other objectives have progressed over the years. So what we have decided to do as an exec team is to focus our objectives through the lens of our patients, so that everything that we do, whether it's looking at our buildings, whether it's looking at performance, it's all done through the lens of our patient. And not only that, but agree a set of ambitions that where we want to get to. So not just focusing on the next sort of 6-12 months, but really what do we want to achieve as an organisation over a period of time. We've moved from a relatively small organisation, a sort of £150 million organisation, to a budget now of circa 300 million. And so we know we have to change, we know we have to be more structured, and we know in order to keep ourselves fresh and focused, we have to make sure that we challenge and we continue to challenge each other and our organisation to be better. And using data and information to support and evidence the decisions that we're making. So on the back of that, we have a refreshed set of objectives that I would like to present to the board today through that lens of the patient, and focused on keeping you safe, improving your experience, and ensuring you get the most effective treatment. And you will see that the 7 enabling objectives below that is all about what a patient can expect when they come into our organisation, and what we will do for you as a patient. And it's a very, very different lens to look through our objectives at. And for each of the objectives, I propose not to go through them now, Chair. I'll take this off and say that what I'd like to be able to do is propose that our committees, our board committees, are allocated the relevant objectives that they can monitor and ensure progress against those objectives, and report back to the board accordingly over time. So it's a relatively quick run through, and what we will do on the back of this, if it's supported, is get these out to the organisation, make sure that everybody incorporates them as part of their appraisal process. And in the same way that we have our values on our organisational walls, I think it's important to promote our objectives so that patients coming in can see what they can expect us to do to support them when they interact with our hospital in our place. So I'll pause there, if I may, Alison, and take questions.
Thanks, Joe. Yeah, I think it's probably worth noting as well that we had a discussion at board as well in terms of the strategic objectives, and in light of the pandemic and the impact that had on so many things, particularly that sort of strategic direction. It was felt that it was right to maintain those objectives, but as you say, with a new emphasis and making it much more sort of patient-centred, which we felt was very important. But yes, certainly going to the subcommittees will be great, because we can have the detailed discussion there that we might need. Does anybody have any questions or comments on that presentation? Sorry, Lucinda, we'll have to take, it's just a meeting in public, so we can take your question outside at the end, if that's okay. Thank you.
That's great, thank you.
Okay, thanks very much. Okay, so colleagues, we're happy. Okay, thanks, Joe. We'll take those into the relevant subcommittees, and it will come back to board once those discussions have been held. Thank you very much. Okay, going on to the next item 7, we've got the patient story. I'll be handing over to Nikki, but I think hopefully, I'm not sure, I think Vicky Burns and possibly Lizzie Marsh were going to be here today, so welcome if they are, but otherwise I'll hand over to Nikki.
Thank you, Chair. Yes, I'd like to introduce Vicky Burns, who is our lead nurse for dementia care here at the Trust, and she's going to do a presentation and talk through a patient story and some of the initiatives that we're undertaking. If you can come on, Vicky.
Hi, good morning. I'm Vicky. I'm the lead nurse for dementia care. I've been in this role now just over 2 years, and I've been at the Trust since 2014. I'm just going to share with you my presentation. Is that okay? Can you see that okay?
Yes.
I'm here really to present not only the patient story, but just some of the initiatives that we've been doing in terms of our dementia patients. So during COVID, we identified that some of our patients with dementia, due to the necessary restrictions in visiting, were requiring that little bit more stimulation than maybe some of our other patients. So myself, the vulnerable adults nurse, as part of the safeguarding team, approached the charity, who helped us create a Amazon wish list where we got dementia puzzles, colouring books and puzzle books to try and help stimulate them, along with dominoes and cards and also radios. Another thing at this same time that we did is adapt the Alzheimer's Society Hospital Passport, the This Is Me, which is a document created by Alzheimer's Society that gives caregivers that more holistic view of our patients. So right down to the nitty gritty, how do they like to have their tea? How do they express pain? And how do we know when something's not quite right? At that time, we felt that we wanted to adapt that into a much more inclusive document, and we created our own local document, which is called What Matters to Me, and that allowed us to bring in other groups of patients. So our patients with a learning disability, maybe patients that were experiencing delirium, and also those patients with a much more complex need, so motor neuron disease or Parkinson's. Alongside that, another thing that we got was our robo-pets. So these have been really well received. There's a lot of scientific evidence out there that shows that just pet therapy in general is really good for our health. So lowering our blood pressure, helping to release endorphins, creating that calming effect. There's evidence out there that it can help reduce someone's experience of pain, and also lifting and people's spirits. So we have some of the little kittens and some of the little puppies. They're of a synthetic material, and they are quite plush, and they have a breathing motion. So they're about the size of an A4 bit of paper and about as high as probably a mug. So they're quite substantial, and they're easy enough for a patient to have a hug with. So at the moment, the allocation is currently done through myself and the vulnerable adults nurse. And we try to liaise with families in the first instance to ensure that, first of all, the patient likes an animal, and if they've got a preference between cats and dogs. Once we've allocated the robo-pet, we give that to the patient to keep and take home. This is for two reasons. The first reason is for infection control reasons. We can't decontaminate them in between patients, which is why we're being quite stringent at the moment with who we allocate them to, because we want to make sure that they're effective and they're used. And then secondly, on a morally and ethical sort of situation, if it's bringing comfort and calm to somebody, we just felt that this would be unfair to take away. So I wanted to tell you about a patient who we gave kitten to, who worked really well. So Mary was a 92-year-old lady who was diagnosed with mixed dementia. So she had Alzheimer's, but also vascular dementia. She was admitted onto Ward 19 in May of this year and was being treated for aspiration pneumonia. And while she was on the ward, the staff identified that they felt that she was in a lot of distress at times and was expressing that she was in pain and felt short of breath. So I went up and I had a long conversation with Mary, and I offered her one of our kittens. At first she wasn't too keen, and she told me quite strictly that it better behave, and that but she would look after it for me. I went back a couple of hours later, and she was laying in bed with it on her tummy and stroking it, and I already noticed that she seemed calmer. When I asked the staff around her how they felt the kitten had enhanced her experience at that time, they also felt that just in that short period of time, she seemed calmer and as I say, laying there stroking it. So this was on a Friday afternoon, and on the following Monday, my colleague, the vulnerable adults nurse, was speaking to Mary's daughter. And Mary's daughter was really positive about the kitten and felt that in her booked visits over the weekend, her and had already witnessed that she was much more settled. And she was talking about it. She couldn't quite remember where it had come from, but she told her daughter that she knew that it was her responsibility to look after it. And they had a long conversation about this kitten. The ward expressed when I went to them later in that week that she remained calm and she went home with it, and she was discharged later that week, which was really positive. And I've given out a couple more since, and we're constantly trying to get the word out to the wards that they're available. So if patients are really distressed, or even if they're not and they're just unsettled, it's a tool that we have to support them. So a couple of the other things that we're trying to do is adapt our environment. So we received some money and we ordered some items for the environment, and Ward 18 have received the bar. Ward 18 is a male medical ward, and sometimes the patients just need that stimulation. So they have a vision, the ward manager has a vision to create a social club in their day room, which they would like to do activities such as dominoes, cards, even darts safely, and quizzes. So the bar is there, and we're planning to meet with the charity shortly to see what support and funding we can get to decorate that room. And Ward 23 received our market barrow and also the phone box. The ward manager there is really keen to get the phone working so that it is actually a useful tool in getting patients up and walking to the phone and using it to call family. And then also using the market barrow in a very similar way in their day room, so that patients were encouraged to get up, walk to the barrow, get whatever they need, whether it's an activity or cakes if they were to do an afternoon tea that day, and then take them back to a communal table. The ward manager has this lovely idea of encouraging the patients to sort of buy the items with like a monopoly money as such that would be sort of given out prior to. And then the next thing is our meaningful activity facilitator. So a lot of care homes have activity coordinators who plan and implement meaningful activities with their residents. And this was something that I had a conversation with our charity and felt that, was this something we could look at to see if we could deliver here in hospital? We did a search to have a look if there was any other trusts that did something similar, and we came across the University Hospital of Leicester, who have quite an extensive team of meaningful activity facilitators. They started a trial in 2011 with just 2 people, and now they've got a team across their hospital, and it's something we're very keen to sort of emulate. So working in collaboration with the charity, we've got funding for a 1-year fixed term full-time post, which was successfully recruited and hopefully will start at the end of July. The plan for this role is to cover all of the frailty wards to start with, working closely with the ward staff and the therapy staff, making sure that activities in that area are meaningful to the patient, but also there's some therapy support behind it. So encouraging, mobilising and helping to reduce that risk of deconditioning. This role is only a pilot, so we hope to evaluate it using measurables such as hopefully a reduction in falls, or pressure damage, and some violence and aggression, and then hopefully to look for establishing funding to expand the team. So our next steps are to to introduce our mindfulness and meaningful activities where appropriate in those areas to start with. Continue to use and support the use of the robo-pets where appropriate, and enhancing our day rooms on particularly Ward 1823 to start with, but where else we can look in the future. And then evaluating the meaningful activity facilitator and ensuring that we can successfully take it further. And thank you very much for listening.
Thank you very much, Vicky. That's great. What a fantastic ideas. I think I've seen some of these wards in my previous experience in mental health services, the difference it makes to have environments that people recognise. Now I've got a couple of hands up from colleagues. So Hader.
Thanks, Alison, and thank you, Vicky, for a really, really great presentation. It's really wonderful to see how holistically you're looking at the care and well-being of our patients. So thank you to you and your team for that. And I'm really glad, as chair of the charity committee, that we were able to support the role that you mentioned. And I hope that we can continue to work together and support the good work that you're doing. Thank you.
Absolutely. Thank you.
Thanks, Hader. Nikki McLeod.
Thank you. Thanks, Vicky. I just wanted to say how much I enjoyed that and how inspiring, you know, the whole thing with your initiatives and the ideas that you've come up and almost brought a tear to my eye with the kitten thing. I mean, it's just so simple, so straightforward and so effective that it was absolutely delightful. And just to say thank you to you and your staff, because this is such a difficult area and so, you know, complex patients to work with. And I think it's just amazing work. So just big thank you. Really.
Thank you.
Thanks, Nikki. Helen.
Yeah, Vicky, I just want to echo what my colleagues have said, but I also wanted to know, I know firsthand, having my father-in-law looked after by yourself and the team, how remarkable and wonderful the care was. And although he didn't have a kitten, he did have a knitted thing with lots of bells and different things that he could feel and touch, and how immediately that calmed him down as well. But I also wanted to say that actually your care extends way beyond the patients themselves, and actually the care that you bestow on the families and the individuals in it as well is to be commended, because it is much more far-reaching than the patients themselves. So thank you for your presentation and everything that you do.
Thank you.
Thanks, Helen. Kate.
Thank you. Absolutely, Vicky. It was a wonderful presentation, and also I know it builds on lots of work that you've done over a long period of time around meaningful activities and distraction and de-escalation around patients who are potentially violent and aggressive. And the board might not be aware of that, but Vicky and the team have done some extraordinary work on really complex, difficult wards, and it's really inspiring, I think, the work that you've been doing. Through the Charitable Funds Committee, we've talked about supporting more of this work and about making dementia one of our appeals through this. So I look forward to taking that through with Hader through the Charitable Funds Committee. So hopefully we can provide you with some more support around piloting some of these great initiatives. Well done.
Thank you.
Thanks, Kate. Yeah, Vicky, I just had one question. Sort of thinking about the activity coordinator, presumably working with patients and their families, it will be very much around identifying the sorts of things individuals like to do in the past and finding what will help with that. I was just thinking that not that I know many, but you know, the odd person who might be teetotal might not want to go into a bar.
No.
But I think that's great, because that sort of individualized support is just tremendous. So yeah, as all my colleagues say, thank you very much for everything you do. It's marvelous.
Thank you.
Nikki Burnsmere.
Thank you very much, Alison. Thank you, Vicky. Yeah, so just to your point, Alison, so we are reviewing all of the activities, because I think we need to sort of move away from the virulin and thinking that everybody wants to do post-war things, because some of our dementia patients are quite a lot younger. So I think we need to move it up a bit to the 60s and 70s. And so we've been looking at different activities. We find it easier for the ladies. We find activities much easier for the ladies, and for our our male patients, that is a bit more tricky. So hence the bar. I mean, really, we could do with a garden shed and things, but we'd have to think about tools and all that sort of thing. But it is much harder actually, and we see more of the violence and aggression with some of our male patients. So it is, but we are reviewing all of that and trying to see how we might give a cross section, so we don't sort of pigeonhole people into things that we think they've done in the past.
Yes, and I suppose, yeah, and I mean, and in addition to that, obviously there's the demographics as well with our population and patients coming in. So I'm sure there will be, you know, some real differences in what people remember and what helps them to be pacified. So lots of really exciting stuff, I think, to do around that, which is very interesting. Look forward to seeing how it progresses, Vicky, and thank you very much for doing your presentation. That's really great.
Thank you.
Okay, take care. Okay, thank you very much for that. And we go on to Incident Improvement and Learning Report. Kate.
Thank you. This is a summary report which you regularly see at board. It summarises the serious incidents that we've reported through what's called the STICE system. That will be changing quite soon as we bring in a new framework nationally around patient safety. There's a summary of incidents. I won't propose to go through them. We will see some changes to this report over the next couple of months because the Ockenden recommendations, which Nikki will go through under the next agenda item, recommends changes around how we report maternity related incidents to the board, and recommends some ways of doing that to increase transparency, and we'd like to apply those principles across all of our serious incidents so that we have a parity across how we report and the type of information, and ensure that we're transparent across all of our reporting, and we're always looking at ways in which we can do that. The report also talks about some of the improvement works we've made and that are ongoing over the last month particularly, and some changes to pathways as a result of learning from serious incidents, and also an update on the Appreciative Inquiry Programme, which over the last few weeks has focused in the emergency department. And that programme of work continues as part of our quality improvement and Appreciative Inquiry Programme combined, to really explore and expose some interesting issues around positive practice that we can learn from, and issues that we will pick up in how we improve both working practice and also care for patients. And those reflections are summarised in the report paragraphs there. We've talked about that in a bit more detail at the Quality and Clinical Risk Committee as well. This report also talks through nosocomial, that's healthcare acquired or hospital associated COVID infections. I think Ian might want to say a few more words about that, but this just talks through the figures for those people who we have established acquired COVID in hospital, and who died, and where that is a probable or definite healthcare acquired infection. We have been communicating with those families. We have written and are in the process of writing with care summaries and reports to all of those families affected. And again, just as part of our legal duty of candour and our moral responsibility around transparency. And you can see here there's some information about where we think we are in terms of in comparison to our peers across the country in terms of hospital acquired infection, and we've discussed that I think previously at this board. This information obviously is available publicly through our board and also on our website through our disclosure scheme too. I'll bring you in at that point to say anything more about COVID.
Thanks, Kate. So this is on page 17 and 18 of the report. As Kate says, we've previously looked at some of these figures, but the work that's been done since we last discussed the issue involved a review of death certificates to try and ascertain whether patients died of COVID or with COVID, i.e. whether it was incidental or whether it was likely causative. As I've said at public boards, as Joe said at public boards before, it's of course a source of profound regret that any patient under our care has died through a nosocomial infection. And that remains the case, and clearly we're very, very keen to learn anything in terms of what we could do differently when faced with either this pandemic or indeed future infectious pandemics to safeguard our patients. I think one of the key messages, beyond those individual narratives, and there are a large number of patients and families affected by this. But beyond those narratives for the sort of assurance of the board, our experience in Milton Keynes of COVID, both in terms of nosocomial COVID, and also in terms of the outcomes for the patients that we've seen and treated for COVID, are very much in line with the national expectations and the national average. And on page 18, it shows us the mortality rate for those patients admitted to hospital with COVID, and we are right in the middle in terms of national benchmarks and other organisations. And I think that tells us that the thresholds for hospitalisation with COVID and the way we're managing patients with COVID are very much in line with other organisations, which I hope is some source of assurance. I think there's just one other thing I think is probably worth mentioning at this point in the board meeting, and whilst we're talking about incidents, and that is an incident we previously discussed, which was a case of esophageal intubation. Unfortunately, the patient died last August. Just to brief board members that the inquest into this case, inquest touching into the death of Mrs. Glenda Logsdale, is ongoing at the moment. We expect it to conclude today. There's been some press coverage already, and it may well be that by the end of the board meeting we'll have the outcome of that inquest. Thanks, Chair.
Thank you very much. Thank you both. Yes, okay. Yes, do let me know, Ian, if you need to, or Kate, if you need to update the board towards the end. So thank you for that. Okay, colleagues, any questions at all or comments on the paper? Just mine then. I'm just curious to know what the visually presenting creative tools is. It's on, I'm just wondering what that is. I think it's in accident and emergency, sorry, ED, emergency department. I'm showing my age there. Does anybody know what that is? That posters or Ian? Thank you.
So as part of appreciative inquiry, one of the techniques used is essentially a range of pictures is presented to a member of staff or a member of the public or a patient to help them articulate in narrative how they feel about a certain scenario. So pictures and narrative are both very much key to appreciative inquiry. I think that's probably what it's referencing.
Oh, great. Thank you very much. Because I know we're going to have something at the board. We're going to go through this at the board. That's really helpful. Thank you very much. I'm ahead of you see. Hader.
Similar theme, just on the appreciative inquiry, I thought it was great to read about the student nurse that worked the line Costa style, you know, and just going back to our focus on patient experience, I think it's these small interventions really that really have a massive effect on patients and their families. So some really, really great work being done there. Thank you.
Thanks, Hader. Absolutely. Thank you. Thanks for the update. We'll go on now to item 9. Nikki, over to you, maternity update.
Thank you very much, Chair. This is an update against the Ockenden review. So we have submitted all of our evidence, over 200 pieces of evidence, to support all the recommendations. That's now gone to region. It will be RAG rated. There's been a delay in that because I don't think they'd anticipated the amount of data that was going to be submitted. So we will then get a report back, and any areas for improvement will require an action plan, which we will then take through our maternity improvement group and to board. We've also this week received the response back for our bid for funding that we've requested for midwives and training and obstetrician. It's come back as a LMNS, so across the system. So we now need to work through how that is proportioned out to the different organisations, and we can update once that's been agreed. Happy to take any questions on that.
Thank you very much. Any questions from anybody? Helen.
Thanks, Nikki, for the update. I just wanted to ask about the funding, and you've just updated. But my question was, what happens in terms of change in practice, etc., if that funding wasn't successful?
So I think we need to understand what we will receive out of the can't get my words out. We need to understand what we will receive from the funding bid to then come back to board to say what are we committed to take as part of the original ask for Ockenden to meet all the requirements. I couldn't say today because we haven't agreed what is going to be proportioned to us.
Yeah, is there a confidence that there'll be the funding that's required or not, Nikki?
No, I'm pretty confident looking at it, what we
Yeah.
asked for.
Good.
It just needs a negotiation and a very sort of fair share across the LMNS. And we've got a very good relationship within the LMNS, and all of these pieces of work have been done in collaboration. And so it's really understanding where the highest risk is, and then have a fair share of the funding for each of the organisations.
Thanks, Nikki.
Thank you. Hayden?
Thanks, Alison. Nikki, I noted that one of the challenges was around extraction of data from eCare, and I was just wondering if you could expand a bit on that and what's being done to resolve that.
So I think lots of work's been done on that. We've done a diagnostic, so not all of the information that is in eCare drops out nicely into audits and plans. So there's two parts to it. Part of it is the actual build, the Cerner build for eCare, and part of it is user. So we've done some diagnostic work, and we do some training for the user part. So that's to make sure that particularly the midwives are putting it in the right place within eCare that will naturally fall into the audit extraction of data. And the other part is we're working with Cerner to make some build changes to make that process happen in a much slicker way than it does currently. I might ask John to come in and explain it in more depth, because I understand it, but it isn't necessarily my area of expertise, I would say.
Thank you, Nikki. Happy to do that, or Hayden, we can take it offline. But in essence, Nikki's described it accurately, that this is, I think, a weakness in the Cerner offering, which is, we've been struggling with for actually several years. There's a new release coming out in the next couple of months, which is hopefully going to make life better. But it is, the maternity system collects hundreds of different data fields, and is a very sophisticated system. And there are, as ever with Cerner, there's lots of different ways of entering data. And if you don't do it exactly in the way that it was intended, then the data doesn't flow through. So there are some issues which have been recognised. We're treating with high priority, and I think our patience with the system not being able to provide the data that we need has expired, and we're trying to ramp up our efforts.
Thank you.
Thank you.
Thank you very much. I can't see any more hands, so thank you for that, Nikki. Going on to item 10 then, again, that's back to you, Nikki, the clinical negligence scheme for trusts.
Thank you very much. I think the spreadsheet that was embedded within the invite, people weren't able to open, but I've sent round a new one. I think Kwame has that as well. So this is just the evidence that we met all elements of the CNST, so it needs approval through board. I would say that there's been an extension to the time frame, and they're planning to make two changes to the different elements. So the PRMT, they're planning to make some changes. Now that's around external review. So we don't know what they are yet. We don't know what the wording is, and we don't know what they're asking us to make the changes are. So I'm asking that we approve the CNST as is today, and whether, Chair, you could divulge responsibility for myself, Ian and Helen for when the new recommendations come, and that we've got the evidence to then approve that. And it has to be signed off by Joe, actually. But it's just two new elements, and they've extended that, and that only came this week. I'm just conscious it needs to be signed off at public board, and so for July, otherwise it's September, and we'll miss the date for submitting.
Yes, thanks. Ian, do you want to come in on this as well?
Yeah, so I think really just to reinforce the message that the goalposts keep on being moved very late in the day, and I think that sort of devolution for the three of us, myself, Nikki, and Helen, to advise Joe and provide assurance to Joe would be really helpful in terms of submission. The one specific thing it would be good to get the board's direction on today, and you'll understand that CNST essentially likes to have a very standardized process across all boards in the country. So it feels like a slightly strange request, but fetal monitoring training, the view of CNST is that 90% is the appropriate threshold. So the staff, the relevant staff groups 90% or more of them should be trained in fetal monitoring. That seems to Nikki and myself a very reasonable standard, but essentially as a board we have to adopt that and have it mentioned in our minutes, as I'm conscious it's a very prescribed system of evidence. If we could approve that, unless there are objections.
Right. Okay, thank you very much. I'm sure, excuse me, I'm sure colleagues will be happy to confirm that. Joe.
I'm conscious of the huge amount of work that all of this has taken to pull together, and I just think we ought to go on record to thank Nikki and Melissa and the maternity team as a whole, who have been working so hard on this. It really has been a massive effort. So I just want to say thank you.
Thank you. Yeah, absolutely. Okay, well, if everybody's happy, I just had one question on this, just in light of the conversation we've just had on the previous paper, getting the information off eCare and things, because there's a reference in here around data and that sort of stuff, which we've said is okay. So presumably the two things are slightly different areas. Is that right?
Yes. Yeah. Different audits.
Yes. Okay, that's great. I just needed some clarity on that. So if colleagues are happy, so it will be Ian, Nikki and Helen looking at these other two areas. And presumably then, Helen, you can feed back to the non-executive group as well. I mean, obviously, because then Joe has to sign it off. So if colleagues are happy with that, we can approve what we've seen today and then delegate to the three of them to look at the other two areas. Everybody happy? Yep, great. Okay, thank you very much. Thanks, that's approved. Just turn over my agenda. Page item 11, the nursing staff update. Again, back to you, Nikki.
Yeah, thank you. Thank you, Chair. So this is the staffing paper. Just to say, in April and May we had increased amount of admissions and a reduced amount of COVID cases, but we were required to keep the facility open because for when we do have COVID patients, which did impact the CHPPD. Recruitment has been very positive. We've got minimal band 5 vacancies now. I think we're working through a workforce plan across the summer. Many of these vacancies, as you'll see later on, we have offered 45 newly qualified nurses posts in the organisation, many of which have taken up that opportunity and have stated the reason why they want to come here is that they've done their third year placements and that they've been very well supported by the trust and want to have their take up employment here. We've been undertaking some establishment reviews and they will all be completed by September with potentially associated changes in the budget of different roles. We've got nursing associate role, which has now been in place for 2 years. And we now need to substantiate that within the skill mix. And as I spoke about aboard previously, we've increased our number of our band 6s, junior sister and child nurses on each shift. So we now need to look at our skill mix reviews and make workforce plans for those. And then we, as you will be aware, we've had our staff awards and many of the nursing midwives received awards, which are just on there. We celebrate. Happy to take any questions.
Thank you very much, Nikki. Any questions from colleagues at all? Helen.
Nikki, it's not so much a question, but I don't want to repeat myself either, but I just think that we should note the success that's contained in this paper, and especially around, as you mentioned, the recruitment of the band 5s, but equally the healthcare assistance programme as well. Reading it is really incredible, and you've done this despite the challenging year that you've faced. And I just, right through the report, there was the mention of the workforce matron, and it just seems such a successful role. I just wondered if there was any, is it likely that this role will be replicated, or is one workforce matron enough?
Yes, one is enough, because I think with the next piece that the workforce matron will move on to is retention. So I think so. Yes, one is absolutely enough, because actually all matrons have recruitment and retention as part of their remit. This is just her very specific one focus and does the oversight, but she works collaboratively with across the matrons and the divisional chief nurses. But yes, I would say that's enough.
Yeah, thank you, Nikki, and once again, thanks for the paper. Really some remarkable stuff, and well done to everybody.
Thank you.
Thanks, Helen. Thanks. Can I just one question for me is around obviously the charts and showing the fill rates. I assume our ambition is to have 100% fill, and so we're comparing with 100%, are we, or is the percentage fill rate that's deemed okay slightly lower than that?
Yes. So as all the staff get into post, then obviously we won't have as many gaps to have to fill from bank. And so each of those ones that aren't filled, because you'll see the nights gets filled, so we don't have any problem doing the bank for nights. So so I suppose we would do mitigation for when it's not filled. That we still are not back to pre-COVID. It's still a little bit skewed. If you look at Ward 22, it's very high, and that's because because that's our COVID ward. So I wouldn't say that it's quite difficult to compare it at the moment.
Okay, no, that's great. Thanks very much. It's just me looking at the figures and trying to make sense of them. My usual thing. Okay, any other? I just echo Helen's congratulations as well around the healthcare support workers. I mean, that was an astonishing piece of achievement, actually, in light of everything else. So, any other questions? No? Okay, thank you very much. Thanks, Nikki. Going on to 12 workforce report. Danielle?
Thank you. So just pull out some key facts through the report. So as Nikki's already alluded to, there's lots of work being done across the teams in relation to recruitment. The HRBPs are working across each area to look at all the posts that we currently have vacant to make sure that we're actively recruiting to them, and where we need to doing innovative recruitment campaigns and trying to reach out to people who may be looking for work and want to come and join us. Sickness levels have continued to reduce. We have seen a small increase of people needing to self-isolate again now, nowhere near the numbers we had at the height, but unfortunately not the 1s and 2s we've seen of recent weeks. So we're starting to creep up again, and we continue to support staff through the process, whether they're isolating because they themselves are unwell or a member of their family is, or they've had a contact, etc. So continuing to monitor that. Our employee relations cases are still at a reasonable level. You may recall a good while back now, we moved to a fair and just culture policy, which encourages informal resolution far earlier in the process before things escalate into formal grievances and counter grievances, and that's still going very well and being well received. Statutory mandatory training and appraisals. We still continue to do well in them, even against the backdrop of lots of extra work and people isolating and what have you. So that's going well. Our wellbeing work, you will have seen we did lots and lots of work over COVID. We've continued this. We have lots of offers available, support offers available to staff. And most recently, we've got an additional on-site counsellor who I think starts this week or next week. And so that's been really well received, because some staff have come forwards and said the telephone counselling's great, the individual video counselling's great, but they didn't want to do it at home by video, they didn't want to do it at work by video. So having an extra person who we can get on site now has been very well received by staff, and we'll continue to develop that as we go forwards. Also want to thank Nikki for taking on the role as the NED for Wellbeing Guardian and Wellbeing Champion. So I know the team have been briefing Nikki, and we've been on the good work that's been going on, and we've restarted our Wellbeing We Care group as well, which brings all the initiatives across the trust together. In terms of benefits, we're just about to launch 2 new lease car schemes because we had feedback from some staff who work across multiple sites that they've seen slightly better deals for particular models of cars with different other trusts locally. So we found out who their scheme is and we've added them as well, so staff get maximum choice, because it doesn't matter to us how many schemes we run, because all we do is process the payroll side of things. So if staff want more choice, then that's what we've set up for them, and hopefully they'll be pleased when we load these extra 2 schemes. Also, the successful location of the Amazon locker. Those of you who are aware of that or know we've been talking about that now for what feels like a very long time. Finally found a place for that, and again, staff have been really pleased, and they've been really glad to receive that Amazon parcels at work. Moving on to culture and staff engagement, staff survey work. The individual departments are now in their listening event stages. So when people get their detailed staff survey results, the managers of the department, helped by the HR business partner, have a meeting with the staff to discuss what led the staff to report whatever it is they reported, whether it was good or room for improvement, and to come up with action plans to either share the good work or to implement whatever they feel might be missing. So if you recall, when we did this last year, we had some teams that really wanted to do much more teamwork and team building, and we put sessions on for that. But we also had people who said things like, we'd like a new battery for the radio, and our uniforms, we'd just like some new uniforms. So lots of huge wealth of and scale of different requests that will come forwards, and we'll support them as they come forwards as best that we can. And then you might have seen our advertisements for our workshops for the Living Our Values campaign for the Kind of Culture. Please do get along to one of those if you can. There's 2 sets of workshops running. There's one single workshop for all members of staff, and then there's a 2-stage workshop for managers, supervisors, leaders, whether you manage people or you're in a clinical leadership role, and they talk about what makes a good day at work, really bringing our values to life. So what we're keen to have as an outcome of these workshops is for our staff to describe to us, they know our values, but what does that actually mean to them? What behaviours exhibit our values? And so that we can start to take those forwards with our values-based recruitment and values-based appraisals that we've started to do the work for. Finally, our cultural intelligence masterclass. So on our inclusion ED&I agenda, we've got a session booked with the board later in December. Unfortunately, it is a little way away because the dates with the company facilitator just don't quite line up with our board dates, but we've got that in now. Some members of the team have been on the masterclass, and we'll be starting to put that through our values work, so that when we have the outcome of our workshops along with the equality and diversity workshops, then we can bring them all together in our culture and values work. And then there's just one final thing that I have to report so that we can have it minuted, because a bit like Ian describing earlier for evidence to say we've complied with something. You may recall a long time ago we changed to a fair and just culture policy for our disciplinary policy and grievance policy. There was a request following a national review that all trusts moved to that. We'd already done it, so we were fine, but I just need to make a note at board that we have published that on the intranet and in the internet, and that board have been made aware. So that's it from me.
Great, thank you very much, Danielle. Any questions from board colleagues at all? No. Oh, Joe.
It was more a comment really on looking at page 32 and the KPIs for the organisation, and we're in a place now whereby we're consistently above our target of 90% for statutory mandatory training and appraisals, and our turnover rate continues to decline from 9.2 in May last year down to 7.1 with a consistent trend. And I think it really should be recognised, the work that both the workforce team and the supported by others that do to develop the health and well-being agenda, because it is making Milton Keynes an attractive place, not just to come, but to come and then to stay. And I know lots of organisations have problems with retention, and I just want to congratulate the teams that have been involved. And I know it's sort of everybody doing their bit, but it really has had a huge impact on our organisation's ability to both attract and retain.
Thanks, Joe. Absolutely, yes. It's a challenging piece of work, you know, to be able to sort of meet the needs, but also, you know, to respond when people raise things. So that's excellent. Heidi.
I wanted to really reiterate what Joe had said, and I know Danielle will always say that, well, it's not the workforce team, it's not the workforce and HR team alone, it is the wider workforce that contribute to all of this. But I do think that it shines through, and we do comment at the F&I committee on the workforce metrics, because I do often think they show the kind of positivity of all the work that's going on. I suppose I've got a question for Danielle, which is, you know, a lot of other trusts around the country, I know from my contact with them, are struggling, really struggling, and beginning to have great difficulties in terms of recruitment and retention. Do you have any sort of greater concerns for the longer horizon, 6-9 months onwards, with people retiring potentially, etc., or do you think the kind of tactics and plans and work that you've got in place are actually pushing through that kind of problem that others are seeing?
I think, as we've alluded to, you know, we are better placed. We took a decision a long time ago to try to make our environment the best it can possibly be, whether that's through reward schemes or culture on the ground or the tools and equipment, etc. So I think we are a very attractive workplace in comparison to others. I think we are starting to see a little bit now of people starting to go back into the jobs market. We see an increased number of applicants for our own roles, just as we know our own staff will be starting to look, because people, I think, have been fairly static through COVID, and I think there will be a collection of people now who are thinking they might move to another trust because it might be a better environment there for them. I think we are lucky in that we are seeing a large increase in our applicants, and we are getting more people through. So I think we are probably doing better than others, but I wouldn't say we were completely insulated from what you've described. I think all we can do is continue to engage with staff, remind staff that we are listening, we are here. We really don't want you to leave. If something's not right, tell us. We have a really good track record of, if something's not right, tell us and we'll fix it. It's about making, for me, it's about making those staff who traditionally wouldn't say anything find a voice, because we will see the staff who naturally push to the front to share their views, and we're used to engaging with them, and we've got really good mechanisms for them. It's that group in the middle who don't really say anything, and we need to get to those people now and say, what is it that you want? What is it that makes you happy here? Yeah. What can we do if you're not happy? Yeah. So that's our task really going forwards, I think.
I think having such clear steps to the plan is really important. I think there's plenty that all of us can learn from what you're doing. So I think it's really good. Thank you, Danielle.
Thank you very much. Any other comments? No. Okay. Thank you for that. We're going on to item 13 now, performance report.
Thank you, Chair. May I just start with apologies that the narrative document wasn't included, and we'll get that circulated after the meeting. I think a pretty consistent picture as to where we were last month, month 2 May reporting's shown a slight deterioration in ED performance. We continue to be challenged by above average numbers, as we've mentioned before, regularly on a Monday and a Tuesday, seeing over and above 300 attendances through the department, and the challenge of delivering that through green and red pathways continues to be difficult, as have gaps begun to emerge a little bit more regularly now on staffing numbers through ED, and regrettably people like myself being detained at home as schools are isolating children. And I think that effect, we're beginning to track that through the organisation now, but certainly seen a slight increase since last month. Related to that, then the ambulance handovers become a challenge, and again performance against that in month above target and where we want to be. It relates predominantly to those periods of peak activity, but we continue to maintain a good relationship with the ambulance service. And we've mentioned it here before, so for the patients, it's certainly not a good experience, but our numbers are far less than relative performance across the region in that context. From an inpatient perspective, again, we remain challenged around our stranded and super stranded patient numbers. We are maintaining a number of around 40 to 50 patients being retained in the hospital over and above 21 days, usually with a reason they should be being discharged. Our main constraints related to that performance are very much around out of area patients needing to be discharged and worked with social care organisations beyond our immediate boundaries. We have a localised problem at the moment with some capacity on what we call double-handed discharges. So again, complexity of patients requiring packages of care above and beyond what is easily commissioned, which would be a single-handed package of care. And I think I would also draw attention to the fact that Joe's mentioned the elective capacity. The theatre piece actually took place in the middle of June, so it's not reported in our current performance to date, but obviously we have seen an impact over the last 2 weeks of June's performance in terms of the elective performance coming through. I'm happy to pick up questions on the wider report, and as I say, we'll get the narrative circulated after the meeting.
Thank you, Emma. Joe.
Just one of the things in terms of our aspirations around performance, whilst Emma did highlight the challenges around ED performance given the increased volumes that were coming through the department, it's also very clear that we are consistently in the top 3 for the whole of the east of England in terms of our performance, and we're just waiting for some of the national figures to come out to see where we sit for ED performance there. But again, in terms of aspirations, yes, we absolutely want to hit the national target of 95%, but the board should be aware that we are doing very, very well relatively.
Thanks, Joe. I know it's incredibly challenging. We know the impact from the pandemic is big. Hader.
Thanks, Alison, and thank you, Emma, for the report. I was just wondering if you could talk us through the other objectives. They seem to jump out on the report as being quite a big delta between target and actual month performance.
Specifically related to what, Hader? Sorry.
NICE breaches, actual month 45, target for the year is 10. Datex incidents 170. Serious incidents, and I know we've got a bit on that later as well. I was specifically thinking about NICE breaches and Datex incidents.
So I think these are internal reporting metrics that we set ourselves, our turnaround time and completeness in some of this, and then our reasons for compliance against NICE guidance. Clearly, some of the challenges are more difficult than we can absolutely subscribe to, and we undertake the risk assessments in order to bring those through and be scrutinised that we're accepting of that position against those breaches. So there's probably quite a lot of data contained within that it's numerically, just to provide a compliance against non-compliance probably requires a slightly broader conversation, which happy to take offline if that's helpful.
Ian, do you want to come in there?
Yes, thank you, Chair. So I think several points. I completely recognise that on the dashboard, the numbers here are concerning. I'd like to provide some assurance. So, for example, in relation to Datexes, any Datex that's put in will be seen by the line manager and others, and all Datexes are moderate or above go to the weekly meeting, the serious incident review group. So they are reviewed. It may simply be a case of formal closure somewhere down the line. I think both for NICE and Datex, it is important we recognise that we have, over the course of the last year, and certainly in January, February, we were redeploying significant numbers of staff based on the particular impact of COVID in the organisation, and we are still in the recovery phase in terms of some of the governance tasks that we undertake. And finally, in relation to Datex, we are switching over, as I think colleagues know, to a new system called Radar in the autumn, and we will, of course, we need to do a sort of a housekeeping exercise to make sure all the Datexes are indeed closed down before that transfer. It'll make life easier for everybody, as well as obviously being the right thing to do.
Okay, thank you for that. Hey, do you want to pick up further conversation with colleagues, perhaps outside the meeting?
Yeah.
Just to get more detail on that. Okay, thank you very much. Any other questions or comments at all? No, thank you. Okay, going on to the finance report. Terry.
Thank you, Chair. So page 46 in the pack is the financial report for the period of April and May, so for the first 2 months of the finance year. Just starting off by doing a bit of a refresh on what the plan for the first half of the year is, because that's currently the period around which we have funding certainty. So for our organisation, as is seen on page 46, we're looking at a 1.1 million deficit for the first 6 months of the year, April through to September. The amount of funding that has been allocated to the Bedford, Luton and Milton Keynes system is just shown below that. So £834 million to achieve that position. And obviously the expectation from national partners is that that 834 million funding allowance is sufficient to provide cover for all of the costs for the first half of the year. So that's just as a bit of a refresh. Page 47 below then just sets out the in the summary table there, paragraph 8, the performance both for the month of May, which we can see was a £106,000 deficit for the 4 weeks of May. The figures that I'll provide are the control total basis, which is the measure of financial performance that the trust is monitored against. The £106,000 in month deficit for the month of May was £70,000 better than our plan expectation for that same period. The cumulative position, just moving on to the middle set of columns there, for both April and May was a £90,000 deficit for the first 8 weeks of the year, which is tracking at about £291,000 better than again our planned position. Within that sort of aggregate reported position, we are seeing, and it sort of chimes with the points that Ian was making in terms of the level of COVID prevalence in the hospital. We're seeing a relatively pronounced drop off in the extra money that we've been spending on responding to the COVID pandemic, but that's just, you know, looking at the extra money we're spending for it, and not the sort of the way that we're managing the entire resources across the organisation, which is obviously still in a state of flux as we start moving around the use and configuration of different ward spaces particularly. We have also accumulated in the first 8 weeks of the year around £2.7 million of income as part of the government's policy on clearing backlog weight, so the elective recovery scheme. So 2.7 million, that's split broadly. I think it was about 1.4 million for April and 1.3 in the month of May. That particular policy has sort of stepped increments as we go through the first 6 months of the year that start from a step of 70% of clinical activity expectation for April of this year, relevant to the equivalent period in 2019-20, and then each month, so throughout April, May through to September, there's a 5% increase in that level of threshold. So 2.7 million so far. The organisation has reported costs broadly equivalent to that figure, and there's a modest level of prudence in there because there remains still a little bit of uncertainty around the precise administration and payment for the elective recovery fund. We may recollect there are a series of 5 gateways that we have to qualify as a total system. So for the whole of Bedford, Luton and Milton Keynes, and only at the point that we can demonstrate we've satisfactorily cleared those criteria does payment flow. I think there's been some useful clarifications on how that's going to be administered over the last few weeks, and we're hopefully going to get some further clarity and values transacted over the next 1 to 2 weeks. So hopefully a bit more certainty when we come back in a month's time to look at the first quarter. As an overall system, I think it's important to note, so when we look at the consolidated results for Bedford, Luton and Milton Keynes as a system, are indeed tracking to plan. So I think we'd reported for the first 2 months of the year an aggregate performance of about £300,000 surplus. There's some modest ups and downs within that. I think the CCG was just under their planned performance. Obviously our sales are tracking just above, and when you look at the whole of it, we're in line with plan, which is a good position to be, because that just shows that the system is delivering on the expectation from both national partners and central government. Just moving on to the capital and cash position of the organisation. So what we're seeing is a continuation in terms of the cash balances that we hold. So we have a a reported figure of about £48.5 million cash balance at the end of May. It's my expectation, because of the block funding commitment for the first half of the year from the Department of Health and Social Care, that we will have a robust cash position throughout that first half of the year. We are, from a cash and sort of capital scheme perspective, we have expensed about £700,000 for the first 2 months of the year on our capital programme, which is just below the amount of planned capital expenditure that we'd agreed as part of our business plan for the year. I think that's quite typical. So a number of organisations, both across our local system and indeed the wider region where I've had conversations, tend to have a slow start in terms of capital programme. We've seen a good succession of business case approvals recently through the relevant management committees, and it's our expectation as we go through summer into autumn that we really do start getting some momentum into those schemes. So there's no concern on that side of things. And I suppose just to conclude, although we'll come on to the board assurance framework, we have a couple of areas of risk that we're citing on the finance side. So obviously we are keen, as all organisations are in England, to get some certainty for the funding envelope for the second half of this year. I think we'd seen a letter from the NHS Confederation only a week or so ago to the Chancellor, encouraging an early heads up on what that may look like. And indeed, there's a session this afternoon with the National NHS Finance Director, and there's an expectation that we'll hear a bit of an update there this afternoon on that point. And we are also now working closely with our regional colleagues to make sure that the organisation is well placed to secure sufficient capital allocation to meet our spending plans for this year, and that's a note that's been added to our board assurance framework in this month. I'll pause there and take any questions.
Thank you very much, Terry. That's very comprehensive. Nikki.
Thanks, Terry. I'm afraid this is going to be a bit of an ignorant question, and I might have got the wrong end of the stick. But on page 48, where we're looking at activity, could you explain why March next year you're expecting such a magnificent drop in A&E activity, non-elective activity, day case activity? I didn't quite get that.
Sorry, that's a really helpful point to pick up, Nikki, and that's the same. The report we're looking at is the same one that went to the Finance and Investment Committee, and that was recognised as an anomaly and needs correcting. So we are not going to be closing the department or anything in March of next year. I think it was the data set it pulled from had the incorrect figure in. So just to provide a bit of assurance there, we'll get that updated, obviously, for next month's report, just so that that's cleared up.
Okay, that's great. Thanks, Terry.
Thank you. Thanks, Nikki. Any other questions or comments? No? Okay. Thank you very much. So we confirm we've received and discussed that. Thanks, Terry. Now going on to item 15, I do believe, I know Ian's going to introduce, but I believe Dr. Janet Costa is here as well to speak to the Guardian paper. Welcome, Janet. And Ian, I don't know if you want to just do a quick introduction first.
Thank you very much indeed, Alison. Janet, do you want to turn your camera on so everybody can see you? And I'll then introduce the paper and you can
yes,
take
I
over.
have to have the camera.
Fine. No problem. But you can hear us and we can hear you.
Yeah.
So this paper, just really a reminder for colleagues. Back in 2016, which now seems like a very long time ago, there was a new contract for junior doctors or doctors in training. Colleagues remember that contract was ultimately imposed on the junior doctors following a long spring of industrial action, so the first industrial action for 20 or 30 years. Part of that contract involved a new process called exception reporting, which was a new mechanism through which junior doctors or doctors in training would have the opportunity to raise concerns about excessive hours or safety concerns which they encountered during the course of their work. Another thing was the creation of a junior doctor forum where managers and junior doctors come together to talk about key issues relating to their experience and their training experience. A third point was the appointment of a guardian of safe working hours. Now, Janet Costa, who's a geriatrician here in the Trust, is the guardian of safe working hours, and the report in our papers today is her annual report. I think there are a number of things to draw out from the report. One is the number of exception reports that occur across the Trust, clearly where it is they're happening and where they're concentrated, and the outcomes that those exception reports bring. I think the other subtle issue, and one of the reasons which is why I'm talking now, I want us to really raised the profile of this, both internally in the trust and also at board level, in that exception reporting is a positive thing for doctors in training and their experience, and a positive thing for the safety of our patients. So my very clear message is I encourage exception reporting. I see it as a positive thing. I think that message from the board, after we've heard from Janet, would also be helpful and positive. I don't know, Janet, before taking questions from board members who would have read your papers, if there's anything you'd like to highlight.
I think I echo the same as Ian said, that across the whole trust, I always encourage even the trainees and the trainers to continue to encourage the trainee doctors to do the exception report, and obviously as a consultant board to support the trainees, so that obviously they don't feel hesitant or they don't feel that they are scared to raise their issues in terms of working extra hours or their training. So it's a work in progress. Still, we need to change our mindset about the process, the whole process, but it's working well. So that's all I know.
Great. Thank you very much. Thank you, Janet. Thank you, Ian. Before I say anything, any comments or questions from colleagues at all on this paper? Well, I'll kick off just while people are thinking. I have to say, I think this is a really positive thing, actually, and it sits very much with the, the culture that we're trying to promote in the organisation about that openness. And if things aren't working for staff, we need to know, and if, whatever policies, procedures, whatever are in place and they're not quite working well, it's so important that people do raise those issues. We all know that the, staff who feel supported, appreciated, and looked after, obviously that passes on to patients as well. So it's a very important loop that we need to make sure that that we're enforcing. So I think, yes, it's very important that we have these reports and that we are kept aware. We know things go wrong in organisations, so the sooner we know about it, the sooner we can do something to fix it. So I think that's echoing Danielle's statement earlier on. So I think it's very important. I suppose one thing I'd like to ask, Janet, is looking at this, it just seems like the responses are quite quick, when issues are raised. Would you say that's how you feel that reflects things?
So as part of the whole process, the responses needs to be made. If it is anything to do with the safety concern, responses should be within 72 hours. And if it is a normal working hour related, the responses should be within 7 days, 14 days maximum. But I have to admit that I have to always push. I keep emailing the supervisors to act on it within 7 days, 14 days. So as I said, that it's a work in progress. I keep talking to different departments about doing it within 7 days. But I have to, as I said, that I have to push. But overall, it gets sorted within 2 weeks. Yeah.
Great. As you say, it's just something. Yeah, obviously, as people get more used to it, and then it will become an automatic response, won't it? But that's good. Thank you very much, Nikki.
Thanks, Janet. It's a really interesting report. Just looking through, a lot of the sort of resolutions of the exceptions are additional time off in lieu and paid overtime and so on. I just wondered, that kind of implies, there's a lot more work than there is kind of staff. What's the sort of psychological support for the junior doctors and so on when there is a lot of work on and, they are having to do more overtime and so on?
So I don't know if you noticed that some of the exception report, as particular example, that one from the gastroenterology, the lots of report was coming in because there was a vacancy gap at mid, obviously as a registrar level, and that was causing lots of psychological stress among the doctors, and that needed I had to go into the department to discuss with the junior doctors separately what are the stress they are going through, and the supervisor had to come up as a team and have one-to-one session with the doctors, like with the junior doctors mainly, who are working late and have like feeling unsupported. So they do like obviously get lots of psychological stress. And the second incident, especially during the second wave of the COVID, where overnight the medical SHO level doctors, they felt that there are like many acute patients are getting unwell. So that was the time they felt really psychologically affected. And I think during that time, like the consultant, especially the medical consultant, the palliative consultant, they provide extensive amount, I should admit that they provide extensive amount of psychological support. It's sometimes one-to-one support. Like there are a few incidents where I have seen especially the respiratory team, they had like obviously one-to-one sessions, especially the registrar and SHOs from the consultant, and especially I think I should mention one of my palliative consultant. She like went like beyond her capacity to like have this session so that the doctors felt psychologically supported. So yeah, as I said, that it's still a work in progress, but I see like people are being aware of the report and the psychological support and everything, and then supporting the trainees. But there's still a long way to go. Yeah.
That's helpful. Thank you.
Thank you. Thank you. Ian, you want to come in?
Thank you, Alison. So just a piece of housekeeping about how Janet's The Guardian reports going forward. I should have pointed out that Janet's relatively new in role last August, and clearly COVID has been an interesting feature of the last year for this role. But what we intend to do going forward is to have an annual report in public board, as we're doing today. Janet is essentially releasing monthly reports to the trainees and the consultants, because that relatively quick feedback is vital really to raise the profile of this role. And the proposal was to go to workforce assurance quarterly with essentially a compendium of those three reports and an overlying narrative. I'm hoping the board will be happy with that approach.
Yes, that sounds, yeah. I mean, unless colleagues have any comments on that, that seems, yeah, a very good way of having that oversight. And I think it's a very positive thing, and well done, Janet, for taking it on during the pandemic. I mean, that's what an extraordinary extra piece of work to have to do on top of your own work. But I've just got one last question, and that's, it just seems to me that this as well seems to sit very well with freedom to speak up. And I just wonder whether there is going to be a link between with Philip Ball and the other Guardians there, because it is very much around that open culture and the openness. So I mean, it's just one to throw in as to whether or not that might be a good link, actually.
So certainly one of the things we do is we introduce trainees to both concepts, because otherwise there can be confusion between various Guardians. I'm a Caldecott Guardian as well, and sometimes there's confusion with the different Guardians.
Yeah.
So I was going to bring it up at any other business, but actually it probably fits in quite well here, because it's very much trainee related. Members of the board will recall we had some very big challenges in obstetrics and gynecology over the last few years, with enhanced scrutiny from the Health Education England and also the General Medical Council. And we put in an awful lot of work with the trainees in obstetrics and gynecology to improve their experience. Yesterday, Joe and I received an email from Health Education Thames Valley, which essentially was glowing in terms of the work that's been done, and that extends to the Junior Doctors Forum and Janet's input as well. But essentially, just to sort of include a couple of elements, trainee feedback was extremely positive against all of the requirements. The Quality Committee, this is of the Deanery, were keen to express their appreciation for the way the Trust has responded to the concerns raised, particularly outstanding the work around the Junior Doctors Forum. So outstanding in a positive way rather than outstanding way not done. And finally, the risk will now be closed off on the Health Education Thames Valley Risk Register, and we, Health Education Thames Valley, will recommend that this is also closed off on the GMC reporting register. So absolutely no real complacency, and we carry on working very hard in that department and all others around training experience, but that's a very positive news story.
That's great. Thank you very much for raising that with the board, and congratulations to everybody involved in that sort of turnaround. That's marvellous. So as you say, yeah, carry on the good work. That's marvellous. So thank you very much. Unless we've got any other questions or comments from anybody. Janet, thank you very much, and best of luck, and do let us know if there's anything we can do to support as well. Thanks. Okay, going on then to item 16, significant risk register. Kate.
Thank you. Hopefully this paper is fairly self-explanatory. We bring the significant risk register to the board with a brief summary report in front of the main register, which is a very large table extracted from our Datex reporting system through for information and for any questions. You'll see as part of the narrative report, we have introduced a corporate risk register, which I think I talked about before at the board, to help us ensure we have the appropriate scrutiny and management of those risks that reach across the organisation and touch more than one area. And that will start to report through to the Trust Executive Group and the Audit Committee. Otherwise, I'm happy to take questions on this report. As I said, hopefully it's relatively self-explanatory, but any questions, happy to try and answer those.
Thank you very much. Thanks, Kate. Any questions? Heidi?
Mine's just a really simple one. How often does this come to the board, Kate?
It usually comes to every public board.
It will. Okay, thank you very much.
And Hader.
Thanks, Alison. I just had a question. I noted there was only one IT-related risk, but if you read, you know, the background of some of the other risks, then they seem to stem from IT-related problems. So I was just wondering how we classify issues.
Yeah, it's an interesting point and something that we're hoping to capture slightly differently on the corporate risk register. So I think a lot of IT risks might manifest in different departments in different ways, and so those departments end up holding the risk, or they're categorised under those departments. But we are having conversations with corporate areas about how we categorise those, and actually whether those risks need to sit inherently with those different areas. People have different views about how controls are managed and what assurances and mitigations can be put in place, but I think that work is ongoing with departments like IT and information and estates particularly.
Thanks.
Thank you. Thanks. Any other questions or comments? Just one from me really is just around, I'm just wondering where relevant, do we have a system of quality impact assessment? I mean, I'm just thinking sometimes, you know, with finance changes or cost improvements, that sort of stuff, we have quality impact, do we?
Yes, we do. Yeah, we've got an established process for quality impact assessment on those sorts of changes. Yeah.
Great. Okay. Any other questions or comments? No? Okay, thank you very much. So we've received and discussed that and noted it. And then going on to the board assurance framework, back to you. Oh, sorry, Hader.
Thanks, Alison. Sorry, late hand there. Just a comment on risk 8, the improving patient experience one. It had a note talking about the October 21 timescale, but that was dependent on national restrictions being removed. I was just wondering if we had an opportunity to, you know, keep that timescale. It sounds like quite an important one to keep through some sort of virtual mechanism rather than face-to-face, because I'm assuming that's what the national restrictions would not allow.
Is that risk on the board assurance framework or on the significant risk register?
Oh, sorry, yeah, I have jumped ahead. It's
okay.
Yeah, I was just looking I thought I hadn't seen any numbers on this paper, so that's right. We're just coming on to the board assurance, Hader, don't worry. Kate, over to you.
Thank you. So similarly here for comments, we've spent some time talking about this at our last board seminar and about capturing horizon scanning risk, and the board assurance framework will continue to adapt and reflect the changing risk environment, and particularly following on from the agreements around our strategic objectives and how we reflect those updated objectives within the BAF, because that's the purpose of the board assurance framework. Just going down to risk 8, if I take Hader's question, 1 second, let me just find it. So the narrative in the timescale. So I think that shouldn't change with the current restrictions planned to lift in July. So that should be on track. I think there'll need to be some decisions that will be made by Nikki, primarily as chief nurse and the director of infection prevention and control, around the appropriateness of that activity and how we manage that, particularly if cases are rising. But we'll just keep that under review.
Thanks.
Any other questions or comments on this? No. I just had one, Kate, around those areas where they're now marked green. Are they staying in place just to see that that's consistent, or will they be moving off and possibly going on to a corporate risk register if relevant?
I think the risks that have reached their target potentially may well then move on to the corporate risk register. And I think we do need to keep a manageable number of risks on the board assurance framework, otherwise it becomes a document that we can't really get to grips with. So Kwame and I are in the process of reviewing that against the new objectives and looking at where we might want to pull risks down onto the corporate risk register and manage them through the risk and compliance board and trust executive groups, and then what risks come on that are more appropriate for the board to manage.
Great, thank you. Joe, you want to come in?
Yes, thank you, Chair. Two things. Firstly, on page 128 under risk 13, the current risk is showing as 16, but I'm assuming that should be a red rather than a yellow, and the tracker isn't complete, so I just want to make sure that is changed. And secondly, under risk 14, I think it would be remiss of the board on the following page not to register the IT infrastructure and systems increasing risk there. And I think it's worth getting John to comment on how that's gone up and what the plans are to reduce it, just so the board has visibility.
Thank you, Joe. So this is really going up because there's a lot of heat across the world, really, in terms of cyber at the moment. So only yesterday, both Leeds and Blackpool were attacked with a denial of service from a Russian IP addresses, and I think we have to be ever vigilant. There's also a worldwide issue over print servers. So this is something which we respond to on a daily basis, and we will have to keep a track on. So I think the risk is going up with malicious attacks across the piece.
Thank you. Thank you. Thank you, John. Kwame, did you want to come in?
Yeah, just to say that risk 13 is a new one, so that's why the tracker is not showing. From next month it will start showing, and it should be amber. It was my mistake. It should be amber instead of yellow, so I will sort it out. Yeah.
Thanks, Kwame. No problem. Thank you very much. Any other questions or comments on the BAF? No. Okay. Thank you. Going on to the summary reports. Sorry, just getting on, rolling them up on my laptop. I think possibly if I just go through, obviously they're here really for noting, and so unless anybody has any comments, urgent comments, we'll just note them. The audit committee. Yep, noted. Finance and investment. Okay, thank you very much. Those have been noted. We did have questions from the public. Unfortunately, they came in rather late yesterday. So what we would like to do is we're taking those away to look at the questions that did come in, and we will report back on those at the next meeting as well, but also obviously speak with the individual who raised them. Otherwise, as far as I'm aware, I have spoken to colleagues. There wasn't anything else that came in. And it just leaves me to close the meeting, this meeting in public, and thank everybody for their participation and all presentations,